Good afternoon, this is the clerk. Our estimated start time is 2:10 p.m.
I know it's already 2:02. Just to let everybody know that I have a note that Vice Chair Abekoga is running approximately 10 minutes late. So as soon as she gets here, we'll get the meeting rolling. Thank you. Well, good afternoon, everybody. I'd like to go ahead and call the Health and Hospital Committee to order today on March 19th. I'm Supervisor Otto, lead chair of this committee, along with Vice Chair Supervisor Margaret Abikoga, with both supervisors present. We now have a quorum. Moving to item number 2, public comment is a item reserved for comments by the public on item not on the agenda. If those who like to speak, please hand the cards out. If we have any.
I have no requests in chambers. I do have 3 requests online for item 2.
For item 2, okay, 2 minutes each, please.
For 3 speakers, I believe we need 3 minutes.
Oh, I'm sorry, go ahead, 3
Is
minutes
that
each,
right?
please. Yes, thank you, yes, 3 minutes.
Okay. And we'll close the queue at 3 speakers. Our first speaker is iPhone. You'll have 3 minutes to speak. Timer will start when you begin speaking.
Yes, hello, good afternoon. I would like to bring to this committee's attention the issue of child protection. We really do have an issue in this county when it comes to protecting children who are neglected, physically abused, or sexually abused. Just in a span of 1 year, we've had 3 deaths. We had Ellie Lorenzo, we had baby Phoenix, and then we also had Jordan Walker. All 3 passed away in a span of 1 year. We also have cases of sexual abuse that goes uh, without having screenings. Violet Brooks's 3 girls were sexually abused, and nobody cared to do a screening for her kids. Catherine Campbell mentions that her children were sexually abused, and nobody did anything to stop it. There was Daya Baran's daughter, nobody cared, and my own kids. I mean, my son, he's already confirmed that my ex-wife was letting a man rape him. There was unnecessary bathing with the children, changes in personality, sexual contact between 2 of the children. And because of a conflict of interest, the county is refusing to do a screening. Now, we recently had the San Jose Mercury News editorial board who called for the removal of Daniel Little, Wendy Kinnear, and Wendy Kinnear Roush. In addition, Pa Chang wrote an op-ed in San Jose Spotlight. She also calls for the removal of Daniel Little and Wendy Kinnear Roush. Many social workers have come to public meetings, the Board of Supervisors, and asked for accountability because there has not been any accountability. And many parents also are calling for accountability. And I just don't understand. I mean, here I am, and I can't get a screening for my children. Why does the county executive not listen to all these people who are calling for accountability? They're calling for more children being protected. I mean, this isn't like a small thing. This is huge. I mean, if you're a parent and you know what it means to care for a child, why does the county executive not listen to the people? Um, where is the representation? Um, please, can somebody talk to James Williams and please tell him to remove these people so more children can be protected. No child deserves to be sexually, physically abused, or even neglected. Please talk to him. Thank you for your time.
Our next speaker is Michael Rogers. You'll have 3 minutes. We'll open your microphone. The timer will start when you begin speaking.
Can you hear me?
We can.
Oh, thank you. I was going to say thank you very much, Supervisor Lee, for a generous 10 minutes, but I'll try and stick to 3 minutes. Uh, I can easily spend 10 minutes talking about different healthcare issues in the county. I'm the vice chair of the Health Advisory Commission. Tonight, we meet to approve our 2025-26 plan. I want to invite all attendees here. Certainly come join us in the county meeting. We'll add to our work line items on integrative and functional medicine, Medicaid dentistry, toxic control, especially in recent years. We've seen a lot of lead poisoning due to actually spices in the foodstuffs coming from Asia, among other things. But I wanted to quote actually Paul Lorenz from the February Board of Supervisors meeting and talking about how we have to deal with the challenging financial environment going on today. And we have to reset our focus on primary care and preventative health care. That's the right way to care for a community. Provides for better health care outcomes. Our ability to manage chronic diseases early with preventative measures will reduce our number of emergency room visits. I can't agree more. Um, Functional and integrated medicine has the promise to actually get to the root cause of chronic diseases. With a big focus on nutrition and more individual testing, it can provide better healthcare outcomes at reduced cost. Reduced cost. Nick Norwitz from Harvard, who's got a dual PhD from Oxford, is an MD as well, been publishing study after study with populations of workers where they apply these types of approaches and reduce the amount of pharmaceuticals by thousands of dollars per participant in a workplace environment with 30 to 60 different types of people. We spent 2 years at a chronic disease subcommittee. We brought a referral in December of 2022, was approved by Supervisors Committee and Lee, and we're looking forward to hearing from the health system of the county when they're supposed to come to the meeting this spring. I think it's April, but I'm not sure when it's going to be scheduled. So we're very interested in moving this forward as a means of doing things differently. I worked in semiconductors for decades, and we're a very cyclic industry. And when these types of challenges come from the cyclic part of the business on the financial side, we had to figure out how to do things differently. How do we do things smarter? Not just make cuts, not just get down to the bare bones, but how do we do things better so that we can get things done better, improve people's outcomes? Thanks for your time and attention. I'll release the rest of the time.
Our final speaker is Paul Soto. You'll have 3 minutes. The timer will start when you begin speaking.
Good afternoon, Paul Soto from the Horseshoe. 175 years ago today, a man named Tiburcio Vasquez was taken up the gallows right directly behind the post office downtown on St. James and First Street, and he was hung. And there was literally thousands of people, reporters from all over the country. There was literally 2,000 people that converged on downtown San Jose. Tickets were sold to witness the hanging and the murder of this petulant, disrespectful Mexican that dared to challenge the government and start trying to demand that the Mexican be given his rightful dignity and his honor. Because in 1875 San Jose, make no mistake, there was no honor and there was no dignity given to the Mexican. And from that day to this, I can honestly say that both the county and the city governments, I'm talking about governments as a whole, have continually created systems that necessarily depletes the capacity for the Mexican to continue to live and to survive in the country and the city of their birth. Now, with that stated, Dr. Sarah Cody stated that racism is a public health issue. So I'm bringing up this topic within the proper context of this particular meeting, because it is. Now, that is it. Now, racial equity is not an aspiration. It is not an aspiration. Racial equity is a necessary component of the way that budgets are allocated within the county and city budgets in order to address that racial inequity that my community has been forced to endure since war was declared against Mexico in San Jose, July 14th of 1846. So there's a very clear, consistent connection between what happened to Tiburcio Vasquez and his life and the reasons why they took him up those gallows and hung him in this city and what is happening today. Mayor Mahan's rhetoric that's coming out of his mouth is literally blaming the victim for the way that these police departments savagely beat Oscar on the floor. And he's blaming you for it. He's blaming the county. He had the nerve to open his mouth and say, well, if Oscar had been in some kind of mental health treatment or some kind of, that wouldn't have happened to him. This is the kind of insanity and sociopathic apathy that's coming out of that sewer that mayor calls a mouth.
That concludes public comment.
Thank you. So item 3 on the agenda is approval of the consent calendar and changes to the committee agenda. I would like to actually add item 9E, which is a report relating to federal and state health policy and budget landscape, to be heard concurrently with item number 7 and to be heard first. Other than that, I have no other changes. Do you have anything, Vice Chair? No? Okay. All right. Anybody in public on consent?
No request to speak at this time.
All right. Let's entertain a motion to approve the consent.
I'll make a motion to approve the consent calendar with the change.
Yes, and I'll second that. Let's take a vote.
Vice Chairperson Abe-Koga,
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Thank you. Moving to item number 4, recommendations relating to medical staff and allied health professionals at all our hospitals. And in this case, actually also added is Regional Medical Center here. Very exciting. So here to present, I believe we have Dr. Patricia Salmon from the Enterprise Medical Staff President. Good afternoon. Again.
Sorry about that. Good afternoon, Supervisor Lee. Thank you for having me. I'm here to present the Enterprise Credentials Report. And as you mentioned, it does this month include credentials for regional medical center physicians who will be continuing on the medical staff after April 1st. I'm here to answer any questions you may have.
Great. All right. First, Jess, do we have any members of the public like to speak on this item?
No request to speak at this time.
All right, Supervisor. Okay, let's go and close the queue. Supervisor Abe-Koga, any questions on this?
Well, first of all, this is really good news in many ways. It's great to see that so many RMC physicians are choosing to join. I was just wondering if you know how many chose not to, and maybe some of the reasons why they may have chosen to not join us.
Around 436 physicians are staying on, I believe. There are some physicians who are not part of the groups that we are going to be contracting, such as for the emergency department or the ICU or anesthesia, so they may not be staying on, but most of their medical staff is staying on, not necessarily in a contracted position, but they all seem to be really happy to join and watch this hospital grow back and reach its full potential.
Great, thank you.
Yes, I can't be more excited to see that we're moving along with the onboarding of so many of our RMC staff, with those doctors you mentioned. So looking forward to the good news. Again, thank you so much. Let's entertain a motion to approve this.
Motion to approve the report.
Now, I'll second that.
Any public?
Okay. Oh, I'm sorry. Any public would like to speak on this issue? I'm
I
sorry.
believe you called for it. No public comment.
No public comment. Close the queue and let's go take the vote.
Vice Chairperson Abe-Koga,
Aye.
Chairperson Lee.
Aye as well.
Thank you.
I'm so excited. I didn't almost forgot about public comments. Thank you.
Thank you very much.
All right. Item number 5 is report from the Santa Clara Valley Healthcare relating to the acquisition and integration of RMC. And here I believe to present is our CEO, Paul Lorenz. Paul, go ahead.
Great. Thank you, Chair Lee and Supervisor Abe-Koga. So first of all, in following your question, Supervisor Abe-Koga, around the medical staff, so we're very pleased that obviously the medical staff have come over, and I think as the hospital continues to grow in the community in terms of the different types of service lines that we will bring back, we fully expect the medical staff to continue to actually grow and serve the community. With respect to staff, as been reported, over close to 99% of staff onboarded with the county. And as of this week and continuing on to April 1st, we will continue to be training and preparing the staff on multiple fronts in terms of clinical protocols and policy, but also preparing them for HealthLink, which is also going live on day one. I would also share with this committee, outside of the written report, is that we continue to make good progress in terms of our the review and preparation around all of our licensure requirements for the hospital. We do expect CDPH to arrive within the next several days for a licensing survey for change of ownership, and we are prepared for that visit should they come tomorrow or any time before the 1st. The other item I wanted to share with you is that we did have a review by the local EMS agency last week. We do have some items to follow up on, and we will be responding to the EMS agency later this week to ensure that they have everything as we anticipate to launch on day one trauma, STEMI, as well as stroke services. So that is our goal, and from our perspective, things are moving in the right direction. The other items that obviously are also in the report are equipment and supplies and preparation around day one, and that is looking good. So we still have a lot of work to do, but we are feeling good about our preparation for day one. And the other item that I'm sure you're aware of is that we've been scheduling and actually starting on Thursday at the VASC. We will be having a number of different community outreach meetings to engage the community and receive feedback around what they hope to see and what they expect from Regional Medical Center beginning April 1 and onward as part of the county health system. So we are looking forward to those meetings and receiving feedback from the community and the public. And then finally, we also will be launching a media campaign to further inform the community about the transition, increasing awareness of what's going to happen on April 1 and onward. And that campaign actually has started today to give them a preview of what they should anticipate. Once we receive feedback from the community, that will inform our further community campaign and awareness efforts with regards to our media and marketing strategies. So all of that is coming together, and we are looking forward to April 1.
Okay, thank you so much. Let's see, anybody in the public like to speak on this one?
I do have one request in chambers and one request online. Final call for public comment on item 5.
Okay, let's do 2 minutes each.
Thank you. We'll close the queue at 2 people. Our first speaker is Steve Grau.
Yeah, just speak on right there.
Oh,
There's
got
a
it.
building mic.
Okay.
Yep, there you go.
All right, perfect. Good afternoon, dear members of Health and Hospital Committee. My name is Steve Grau. I'm the CEO of Rural Ambulance. For the last 15 years, we've been providing medical transportation to the county of Santa Clara, including some parts of the 911 system with partnership with GMR, and also event medical services for SAP and the Sharks. So it's been a fun journey for us for 15 years. We proudly employ over 300 local healthcare providers. And we've served Regional Medical Center for more than a decade alongside other healthcare systems like El Camino and Good Sam. Last year alone, we transported nearly 1,000 critical care patients from RMC to ensure they receive the right level of care due to sunsetting of essential services. So we're very excited to reboot and bring those back. And first, I just wanted to recognize Paul Lorenz and his team for this vision of building an integrated healthcare system, and the board, of course, for supporting that vision and making it possible. Integrating hospitals into a unified healthcare system is challenging and complex, and transportation is a key part of that system. It directly affects bed availability, patient flow, and access to critical care services. I originally came today because our ambulance service at RMC appeared to be overlooked during the recent transition. And we were told that starting April 1st, just a few weeks ago, that we're no longer providing medical transportation to RMC, including critical care. But thankfully, just a few hours ago, we talked with a county representative and opening the door for continuing our longstanding service. So I'm super encouraged, again, a little concerned at the timeline. However, super reassured that at least we're being heard, and I'm optimistic of reaching quick and cost-effective resolution for the system. Again, our team is ready and eager. My job is to support their well-being, and again, my sincere appreciation.
Thank you very much. Appreciate it.
Our next speaker is Paul Soto. You'll have 2 minutes. Timer will start when you begin speaking.
Yes, Paul Soto from the Horseshoe. Congratulations and gratitude is in order to Paul Lorenz for your work in creating a pathway for this acquisition of this hospital. And on behalf, and as a representation of the Chicano, the lowrider, and the farm worker movement histories here in San Jose, I extend that gratitude to you sincerely, because healthcare was a primary focus of Sophie Mendoza, Ernestina Garcia, Raquel Silva, Shirley Trevino, Kathy Chavez Napoli, Irene Madrid, and the members of 2 organizations named United People Arriba and Confederación de la Raza Unida. Were very much involved in pushing Alexian Brothers, because Alexian Brothers, which is regional hospital now, back then was basically neglecting our community. And so when Dr. Sarah Cody, and I'm not going to let up on this, when Dr. Sarah Cody talks about that racism is a public health issue, the acquisitions of hospitals like this is a necessary component of institutionalizing, addressing that particular statement, because it wasn't just rhetoric that she was stating. This is a reality and has been a reality for my community for at least the past 100 years, contemporary society, at least 100 years. And so what I'd like to do is continue to encourage you to replicate this kind of policy within other contexts that deals with the health and the viability and the life expectancy and life quality of members of my community, because it's a necessary component of what it is that governments do. And so I want to thank you for having this perfect example of institutionalizing racial equity within the context.
That concludes public comment.
Thank you very much. So I do have comments and a couple of follow-up questions about this transition, Paul, as to how major this really is for us. So the data I've gotten so far is that we have 1,055 job offers made as a few days ago to the RMC employees, and that we have a 98% acceptance of our offers, and only 14 employees who didn't. And based on the RMC onboarding satisfaction report, you've got 91% of a positive onboarding experience. So if you run for president, I think you'll win. That's a pretty good number, 91%. Very impressive, Paul. Yeah. And anyway, I just want to say first, thank you, Paul, Nari, and the SCVH leadership for this really amazing work for making all that happen. Now, on the issue regarding service line restoration, the idea is that by April 1st, we will be able to get a lot of the services back, including the level 2 trauma, the STEMI services. And so maybe you could elaborate a little bit more about, are we still on schedule on these really exciting but important services that we will have them on board by April 1st?
Thank you, Supervisor. I just have to share some thoughts, and you're absolutely right. The onboarding process has gone really well, and I do have to acknowledge the Employee Services Agency and their team. They've done a remarkable job in teaming up with our administrative team to make this happen, and that's why you're seeing such good results in terms of the satisfaction. So with regards to the services, as mentioned earlier, from our perspective, given the EMS review last week, we will be able to respond to the questions and the concerns raised in terms of outstanding issues by the end of the week. And we believe, to our satisfaction, obviously EMS agency has to make the call, that we will get provisional designation for these services that we're looking to start on April 1. We will let you know otherwise, but our hope is that we will be responsive to the outstanding issues.
Great. And then one of the not so good news, apparently, is that during the time when we tried to look at the inventory of some of the major equipment in terms of either conditions or or just missing, there are some issues relating to some of these equipment. So I don't know if you want to like talk about now, or maybe it's something that you could give us as off agenda, just to keep us updated how we're able to make sure that those equipments will be ready to go or could be replaced soon to provide those services to our community.
Yes, I can give a report, a written report later, but I would just say in general, we are looking at the inventory very closely and documenting any concerns that we may have relative to missing items, and we will work with county council and others to ensure that, in fact, what we've acquired is in place.
Right. Is there any argument or terms of conditions that any equipment that's being turned over to us in this facility has to be in operational order? Like they have to be working? We do not want to, like, for example, get a broken piece of equipment when we take it over.
Well, our general expectation is that it is an operating hospital and with functional equipment. So that is our view on that. And obviously, if we have any concerns around major equipment, we will work with council and the county exec's office to resolve any differences. And I'm sure James or others may have something to say about that.
Yeah, I would just add that that we do have provisions in the asset purchase agreement that required the HCA to maintain their equipment. So, yes, it's possible that some equipment might have naturally come to its end of life, but the obligation was there to continue to keep all the equipment in working order.
Thank you for clarifying that. I just want to share a little bit of my experience as a logistician in the U.S. Navy. When I was deployed in Iraq for that 1 year, one of the things we were doing is turning over our bases to the local authorities. And one of the requirements is when we turn things over, they have to be operable. And if they are not operable, we actually have to fix them before we turn them over. And that's these are the basic tenets that we need to have, making sure that after the turnover, this place is going to be truly functional, especially the fact that we're going to upgrade the services to a higher level than this currently is. So it's so important that we do that. And I see James, I see your lights on. Go ahead.
Yes, I completely agree, and that is our expectation.
Mm-hmm.
So to the point that Paul and Doug made, we're purchasing an operating hospital,
Mm-hmm.
and so our expectation and the expectation that's codified in the agreement that we reached is that everything's functioning the way it should be in order to have an operating hospital and one that can provide the level of services. You know, we're restoring some services that were shuttered in August, but those services were there in August, so that the infrastructure is in place for running those services. And to the extent that there's any gaps that we come across or identify, those will be the kinds of claims that we will then pursue and follow up, because that is an essential part of the transaction.
Exactly. Thank you, James. Paul? Yeah, just similar to the functionality, some of these equipments tends to have legs during transition, shall we say. So I just want to make sure that we are very vigilant to make sure the inventories is accurate, because once it's transferred, you're not going to be able to claim those.
That's right, and that, you know, that's certainly a concern that we have, and, you know, we will be doing, we have done, and we will be doing our own asset inventory. HCA does its own inventory. There's a reconciliation that occurs, and again, that'll be part of any follow-up process to the extent that there are gaps. I mean, assuredly there'll be some, and then we will be expecting that those be remedied.
Good. Thank you. May I entertain a motion?
Yes, I'm happy to make a motion to receive the report, and I just want to add my real heartfelt thanks to Paul Loren's entire team at quite a few departments, HR, IT, clinical and non-clinical trainers, the employee health department, and also including our labor partners, and just the myriad of folks who've been involved in this, I would say, Herculean effort. It's really exciting. I know we still have 11 days, but it seems like things are really on track. So I just want to say thank you and congratulations. And I'm looking forward to hearing more from the community meetings. I know my staff will be joining at the VASC. And so I hope that we can continue to keep apprised of what comes out of these meetings. And if there's any meetings coming up, especially in D5, please let us know. Thank you.
Yes, definitely echoing those comments of appreciation, and outreach outreach efforts is so important, and that VASC is certainly a great place for that. So certainly second that motion, and if no further comments, let's take the vote.
Vice Chairperson Abe-Koga?
Aye.
Chairperson Lee?
Aye as well. Thank
Thank
you
you.
very much. Moving on to item number 6, the report from the Santa Clara Valley Healthcare relating to improper disposal of medical waste and confidential patient information. And presenting this again is Paul Lorenz. Go ahead, Paul.
Thank you, Chair Lee. Joining me on this item is Dr. Brian Macbeth. Dr. Brian Macbeth is our Chief Quality Officer and has been leading the effort to respond to the concerns brought forward by the DA. I want to turn it over to Dr. Macbeth.
Good afternoon, supervisors and executive leaders. Thank you for the opportunity. I'll be fairly brief here, but I'm happy to take questions as well. You're in receipt of our ledge file that has a timeline and detail around the efforts that we've been making over the last few months. I'm just going to highlight a couple bullet points here. One being the immediate and comprehensive interventions that were taken immediately after we received report from the district attorney around these violations. A couple just quick things to highlight: the shift from our operative and procedural areas to red bag wasting, where we realized many of the biohazardous concerns were coming from. One, and two being the initiation of 100% waste audits from all 3 acute care hospitals from early January. So meaning all of the waste coming out of these hospitals now is reviewed, sorted, and any potential errors recategorized in the proper disposal streams. Second point I would make is just the focus on education that we are making with staff and communication, so trying to understand from our frontline staff where they're having challenges. We've employed a number of strategies, one being a waste management tiger team, which tiger teams were very effective for us during COVID, and we're employing them here again and with good results so far. Third point is just that we are committed to sustainability and ongoing long-term compliance in this area. So we partnered with a vendor that has quite a bit of experience with Kaiser and other healthcare systems correcting these issues. They have been on site starting just in the last week or so, looking at their own audits and helping us build out a waste management standardization program. So I can give more detail, but I won't go into that more now, but just we're very committed to making this right and making it right going forward. Last point just to make is how committed our leadership has been from Paul on down and the commitment of the resources to correcting this problem immediately. So I'm happy to take any questions and speak about any of the specific efforts.
Thank you. James, has your lights on?
Yeah, I just wanted to add a couple comments. First, I just want to extend a lot of gratitude to Paul, to Dr. Macbeth, and to the entire SCVH team for moving very swiftly on this. I want to note something on kind of the timeline that's not explicit in the report. It's our understanding from what was shared publicly by the district attorney's office that they first began this investigation and discovered concerns a year prior. So in other words, beginning November of 2023. But the findings of those investigations were not shared with our system until November of 2024. And I want to commend our system for moving so swiftly, taking the issues so seriously, because they are serious, and moving rapidly to put in place corrective actions, the auditing, many other pieces to address those concerns. And I want to highlight that because not only does the system take its obligations in this regard very seriously, but if we had actually known about the findings and the categories and issues earlier, we would have responded with in a similarly rapid fashion. And you know, our goal, and I believe the goal that's shared by all involved, is to actually address the underlying issues and ensure that there's appropriate segregation of waste. This, of course, is a challenge across health systems in California, period. I think folks are well aware of some of the significant issues that have been found at other health systems, too. That's not by any way an excuse. That's just to acknowledge that this is something that all healthcare facilities are struggling with. And there's a clear commitment from SCVH to put in place all reasonable steps to ensure that there is thorough compliance. So, just a thank you to the team for doing that, moving quickly, but just a reflection on the timeline and how quickly the system did respond once it actually had actionable information in its hands.
Great. Thank you, James. Any questions?
Thank you so much for the report, and I do appreciate the quick action that has been taken. I guess my question goes to the origin of all of this, and do we regularly monitor this, and or will we now so that this won't happen again? I guess I'm trying to understand, and I wasn't here in 23, but how this came about in the first place.
Yeah, it's an excellent question. So, as has been noted, the many systems struggle with these issues. There's a fair amount of complexity around understanding details of how to dispose certain items. It's without going into too much detail, like you can imagine a pharmaceutical in a syringe where there's a needle on the end of the syringe. Do you put that into a disposal for the sharp and the needle, or does it go into a medicinal waste container? Do you empty it first? How do you empty it? So there's a staff educational piece that requires annual compliance learning. So that's part of what has been built in. But we are upgrading that. We are working with our vendor to look at all those pieces. There's a clarity of understanding that goes down to the level of a patient room, where you make the bins look the same in each room and across units. So staff, if they're floating, will understand this is where bio-waste goes, and it looks the same in each place. Even between hospitals, it should look the same. So there are pieces that we are working on improving. Staff are pulled in a lot of directions, again, not making any excuses at all, to James' point. Like, we own this, and we're working on improving and sustaining it. But there are tools that we can give our staff and work on tools that will help them be compliant over time.
And then will we do occasional audits or?
Yes.
Okay.
Yeah, so both of our current vendors, so the one I mentioned is doing 100% audits right now of all the trash, but that's not a long-term plan. That is to get the initial phase underway, and we're going to shift to our second vendor, which is helping us build out a sustainable compliance plan over time. So that is both the educational pieces, it's looking at all the clinics, so we're looking at every area of the health system, so not only the 3 hospitals where the findings came from, but all our ambulatory clinics, custody health sites as well, really looking at our process comprehensively. And yeah, audits, to answer your question, will definitely be part of the ongoing plan to stay in compliance.
Right. And then will we have benchmarks and moving forward, just tracking the progress of?
Yep. Yeah, so there are benchmarks that our vendor, NG Impact, has given us with regards to what we should expect for, we drive to 100% and 0 errors, but we also know in quality that while that's our target, there will be, it's always a work in progress, right? So we'll always have opportunity to improve. But yeah, there are benchmarks in terms of number of findings per 100 pounds of landfill waste that we're aiming for, and we'll be able to report back on in a clear way.
Okay, great, thank you.
Yeah.
I would like to request that we have maybe a quarterly report on this to monitor the progress. Thank you.
Yep, that's fine. You want to make that part of the motion?
Yes, I'll go ahead and make a motion to receive the report and request quarterly updates on the progress.
I'll go ahead and second that. Let's open up a public. See anybody who would like to speak on this?
I have one request online.
Right, 2 minutes.
Our speaker
Close
is
to you. Go ahead.
Paul Soto. You'll have 2 minutes to speak. The timer will start when you begin speaking.
Yes, Paul Soto from the Horseshoe. County Executive Williams is too kind with his, very gentle with his rhetoric. I'm not so gentle. This was a dirtbag cover up and consistent practice. And it rose, that's why I was referred to the district attorney. There's a very specific reason why it was given to him, because this was done, it was organized, and it was done with criminal intention to circumvent the law. And it has nothing to do with training. We just didn't train them right to do this. No, the scope of the issue and the normalization of this practice in and itself is a reflection of the staff. That's a serious problem, because it necessarily exposes the public. And so when you have, there's an additional expectation, and the expectation of a medical facility is going to be necessarily higher than just, Joe Blow, dumping some oil, on the side and creating a hazard for the community. This is different, because you don't have a normal expectation of the preservation of health to Joe Blow. You just don't have that expectation of him. However, you do have an expectation, though, especially a hospital that functions under HIPAA laws. There are HIPAA laws in place. And so the very careless, criminal, and cavalier way in which these medical facilities are handling our information and the bio-waste disposal that they're in charge of needs to check. So I want to thank Supervisor Abacoga for requesting that quarterly report to ensure compliance with these new policies.
That concludes public comment.
Supervisor Lee, if I could just make
Please
one
go ahead,
comment
James.
just for the record, just so that it's really clear. This was not a criminal investigation by the district attorney's office. This was a civil investigation by the district attorney's office, initiated by the district attorney's office, not referred to the district attorney's office. But I think that's really important for the record. There's been no allegations made by anyone, and we're not aware of any allegations of any criminal conduct whatsoever.
Okay, thank you. And I would say that I don't really have a lot of more questions on this specific report, and glad that this has been discovered and that we are implementing corrective measures to make sure that this will not be happening in the future to be unchecked. And this sorting that you mentioned, I think, is going to be very helpful to get the places where they need to be. And one of the things is about additional receptacles, and that I know there's now a plan to use new waste receptacles and training being installed in more places to make it easier so people don't feel, I'm going to say lazy, right, to just not walk the extra steps to find proper receptacles because there are more of them. So hopefully that would help the end result at the end. Okay, without further ado, we got a motion and a second. Let's take the vote.
Vice Chairperson Abacoga.
Aye.
Chairperson Lee.
Yes, as well. Thank you.
Thank you.
Moving to item number 7, which is receiving a report from the Santa Clara Valley Healthcare relating to efforts to address impacts of the federal funding landscape.
Thank you, Chair Lee. Obviously, Bert McGolan will be giving us an update relative to the federal Medicaid challenges that are before us, and we're happy to take any questions after that.
Good. Thank you, Paul. Go ahead, Mr. McGolan. Good afternoon.
Thanks very much. Happy to be with you. Let me start with the latest big development on the budget front. President Trump signing into law the CR last week, which will fund the government through September 30th, the remainder of the fiscal year. The CR includes a small increase in defense spending, and there's also a small decrease in domestic discretionary spending, which is largely the result of earmarks being taken out of the CR. There's earmarks from the prior year that were no longer extended or continued into the CR. So that's the rationale for the domestic spending being slightly less. The earmarks are gone. It does defer the DSH cut, disproportionate share hospital program we talked about at the last meeting. This is that special funding for our hospital system to allow us to deal with low reimbursement rates, uncompensated care. That cut, that scheduled cut, has been deferred again till the end of the fiscal year, September 30th, along with funding for community health centers, other funding for health programs we've been tracking and are concerned about. We all know that Senator Schumer, to avoid a government shutdown, supported the CR, and that was a highly controversial action, produced a division among Democrats. Senator Schumer argued that a shutdown could have accelerated the DOGE process of eliminating government employees. The opponents of the Democratic opponents of the CR were concerned that this is the first CR in history passed without any bipartisan consultation, and the first CR ever that does not contain any report language which is designed to guide administration action regarding the funding. This is important, the report language issue, because without language, with only numbers, no report language, no guidance from the Congress, there's a fear on the part of Democratic opponents that OMB would be able to repurpose dollars within departments, move dollars around, because there's no guidance from the Congress. It's just numbers. And that was part of the concern of the opponents, a worry that passing the CR without report language would be a de facto permission of a sort for the movement of dollars. So now the CR is done. The Congress is in recess this week. When they return from recess next week, they will have an intense focus on the budget reconciliation process, which is, to remind us all, that process by which the $880 billion Medicaid cut would be facilitated, the one that the House of Representatives approved as a potential cut. As we previously discussed, though, the House CR, which passed with the $880 billion, has no effect until the Senate jointly with the House passes a single budget resolution. And the Senate is not on the same page. They have a budget resolution that's much different. In fact, Senate Republican leadership has refused to engage on the budget resolution issue until the CR was passed. So no action was really done or taken on the Senate leadership's part until the CR passed. Now they're in recess. Next week they begin that work. The first action that will occur that will be consequential is Senate Republicans are planning to meet with the Senate parliamentarian next week. And this may sound like a highly technical, unimportant sort of meeting. Inside baseball, why am I even mentioning a meeting with the Senate parliamentarian? Well, in fact, it could have a major impact on whether or not we will face major cuts in the Medicaid program. The House wants the Medicaid cuts to fund an extension of the Trump tax cuts. They need an offset. They need to pay for it somehow. The Senate is resisting that theory, in part because they hope the Senate parliamentarian will tell them that they can extend the Trump tax cuts without an offset. So this parliamentarian discussion is quite consequential. They want no offset, and they want the tax cuts to be permanent, part of the budget baseline. That's what they're arguing here. That's the term of art. If they get the ruling they want from the Senate parliamentarian, there will still be significant Medicaid cuts considered, significant. But there'll be less pressure for the massive cuts that we were the most fearful of. If the parliamentarian says, nope, you can't do that, which most experts think is likely, no one knows for sure, the House position is strengthened because, again, you have to have offsets, and Medicaid stands out there as the major source of an offset to pay for the tax cuts. But no matter what the decision, and we won't know this for some time because the meeting is the beginning of a process next week, we're still in the early stages of a fight that will go on for many months and have many stages. And even a Senate parliamentarian decision to say you can't, you need offsets, you've got to find cuts, it could be challenged on the Senate floor and overturned on a point of order. So nothing is for sure as we move down the road, but this parliamentarian discussion is going to be quite consequential. I want to also note, in terms of advocacy and the environment, that House Democrats called for a Medicaid Day of Action last week, and Mr. Chair and others here on the dais were involved in that Medicaid Day of Action, which was, I think, a very effective way of advancing the argument that These cuts would have a devastating impact on Santa Clara's healthcare system and access to healthcare, and this was done all over the nation. So that was done last week. Two appointment issues, just to briefly update you on. The nomination for director of the CDC of Dr. Robert Weldon, a former congressman and a practicing internist and a vaccine skeptic, was withdrawn by the Trump administration recently, literally 1 hour before he was scheduled to appear before the committee to testify, and no replacement has been identified. So again, doesn't happen very often that a nominee is defeated, but this CDC nominee with his somewhat out of the mainstream views and other issues was withdrawn. Dr. Oz, who's up for the head of CMS, which is the agency that controls Medicare and Medicaid, quite consequential for the county, he had his confirmation hearing, no final Senate vote taken yet. And during the hearing, under cross-examination, he refused to oppose major cuts in Medicaid. He danced around that issue, did not say he would oppose major cuts in Medicaid. He did say he would support Medicaid work requirements, and it's important for us to understand that that's increasingly a consensus view among House and Senate Republicans. That completes my update. Happy to respond to questions you might have.
Well, thank you, Ms. Margolins, for those news. I won't say good news, but news. Let's see. Let me open up the public. Anybody would like to speak on this?
No requests in chambers, but 2 requests online.
Yep, we do.
Okay, we'll close the queue at 2 speakers. Our first speaker is iPhone. You'll have 2 minutes. The timer will start when you begin speaking.
Yes, while it's frightening that we're having so many budget cut proposals, you know, one area that we are going to see an increase in, or it looks like, is CAPTA, the Child Abuse Prevention and Treatment Act. They're allocating a lot more money to protect children who have been abused through Title IV. And the problem is that the states need to be in compliance with this act to receive the funding and the grants. And let me tell you that in our county, children are put in dangerous situations, and the people who are doing it knowingly and willfully. That's why I really think, to be in compliance, we need to remove Daniel Little and Wendy Kinnear Roush, who have a history of allowing children to be abused. I mean, it's a no-brainer that when a child has reported that he'd been anally raped beginning at the age of 13, that you go in and you do a screening. And because there's a conflict of interest, namely Valerie Houghton, she wants this sexual abuse to continue. She's my former attorney. He's just refusing. I mean, it's mind-boggling. That's what Joe Smitty, those are his words, mind-boggling what's going on in the child welfare system. I mean, if you guys don't believe me, go Google Valerie Houghton sex trafficking. I put the details up on several websites. You can read it for yourself, see what's going on in this county. And I don't understand why nobody here is willing to help. I asked Dr. Sarah Cody, I asked Paul Lorenz, who signed the sexual assault response for the county protocol.
Our next speaker is Sean. You'll have 2 minutes. Please go ahead.
I'm so thrilled to have to follow a lunatic. All of these federal policies combined with new local policies will create a catastrophe for our health system. And as somebody who works with unhoused people, that all crashes together. I would also expect an influx of more and more unhoused people and more people without any health care. And this is just going to be a complete disaster for us in the very short term if policy making, if I can call it that, keeps going the way it is at the executive level. And now San Jose has enacted It's lovely, you know, go to jail policy for being unhoused. And so I have this question of, at the county level, you seem to actually hold the keys to all of this in the way of, how is anybody going to know if people have said no to services 3 times, unless they have the ability to look at HMIS? Does that mean that there won't be some HIPAA violation with police, who are the ones who arrest for trespass, looking into HMIS? It seems like there is some sort of HIPAA violation. So I'm asking the county to actually step in and make sure that police have no access to the records of unhoused people, and to ensure that there is no HIPAA violation, and that the county does not cooperate with this system in any possible way. And, you know, I appreciate that the county has made their position pretty clear, but if the county doesn't participate via HMIS, I don't see how the city can carry this out. And I just find it shameful that that now we have 2 cities that think that the best way to deal with homelessness is to criminalize it, when in fact it is a crime to actually continue.
That concludes public comment.
Yes, let's close the public comment period. Yes, Vice Chair, you have any question? Yes, go ahead.
Thank you, Chair, and thank you for the report, although it's not a very rosy one. My question is in regards to the budgets, the federal budget. I know this. We'll talk about the state budget too, and then ours, the different timelines. So given that Congress is on a October 1st fiscal year, and then we are on July 1st, how does this align, or yes, how do we align ourselves?
So the federal picture has always been, a bit complicated. The federal fiscal year runs from October 1 through September 30th. That's been the case forever. And our fiscal year obviously runs from July 1. Most of our federal money, though, is passed through the state. So the state fiscal year aligns with ours. That being said, we're often not aware of state-related impacts until around the same time, or candidly after we adopt our budget. And so then we tend to make adjustments. Now, the reality is, for the most part, most of these programs are relatively stable from year to year. They're in our base forecasts and our base assumptions. And it's really changes in the programs that have to be accounted for, changes at the federal level, changes at the state level that end up. But it is a complicated picture sometimes. What's made things even more challenging at the federal level is this consistent practice in recent years to not actually adopt a proper budget at the federal level. And so, the reality is, for many years now, there's been a lot of uncertainty on spending levels, a lot of kick the can down the road, sometimes 1 month, sometimes a few months, different continuing resolutions. So actually, the fact that this CR runs all the way through the end of the fiscal year is a little unusual. And oftentimes, the process has actually been much shorter in recent years. So we've dealt with that level of uncertainty for a long time by just making reasonable assumptions in our base budget. What makes this year very different, among other things, is the magnitude of cuts that are being discussed to really critical programs for us. And that might necessitate us needing to make really significant adjustments. For the upcoming budget, we will not be assuming changes in the Medicaid program. So, we will have to then look and see what happens. I think it's unlikely Congress will act on that before, the end of our fiscal year. And so that'll probably be something that happens in the fall in reality. And then we'll have to make adjustments moving from there. And that's, of course, our largest source of federal funding. Similarly, on social services, same timeline. So what you'll see in the county executive's recommended budget to the board are assumptions that the current base for Medicaid and for our big social services programs are the same for next fiscal year, knowing that there's risk, very large risks to both those programs. Where we're taking a different approach and different look is with the other funding streams, many of which are already being impacted, but they're not on the same formula type basis as Medicaid and our main social services streams.
Thank you. So I know this goes into the state. I just got back from Sacramento, but there was talk about the 3.4 billion state. But there's, I believe, a loan that's being proposed. Is that? And then there was something else I heard. I thought I heard with the remaining 2.8 billion dollars. And then how does that affect us?
Supervisor, I believe you're referring to the governor's loan
Yes.
request, and it came out around 2.8. Then he increased it based on further analysis. I believe.
To 3.4.
Bert, how much is it now?
It started, I think, at 3.4 and then added 2.8. So it's over
So it
6
covers
over 6 billion.
Yes, and that loan is to address the increased enrollment in Medi-Cal in the state of California related to the state-only program, as well as increase in enrollment around seniors and changes in requirements in terms of asset testing. So
So this wouldn't cover the potential federal cut?
the potential overrun in the Medi-Cal budget in terms of dealing with the cash flow and ultimately going back and requesting additional funding through the legislature process.
Yeah, and the risk for us there is, the state making changes to or cuts in its state Medi-Cal program, which, is very significant. And that could have an effect on us. The loan itself doesn't do anything, but whatever conversations might happen as part of the state's budget process. So that's yet another risk at the state level, separate from and on top of the federal risk, that is quite significant. So, for example, the 1.9 billion number we've been talking about with Medicaid, that's our federal, exposure. We have additional exposure if you start including state-only funds on top of that. And all the things we've talked about for all of our different departments, take public health as a different example, where we've discussed, 30% of the public health department's revenues are federal and federally derived. Well, there's also state funds that support the public health department. The governor last year proposed cutting another $6 to $7 million in public health funding. That's the county impact. The statewide number is obviously a much bigger number. It was a couple $100 million. But another $6 to $7 million in grant funding to local public health departments from the state general fund. So everything we've been talking about for the last many weeks is just a federal picture. And to the extent that something happens on the state side that results in changes to the state's programs, changes to state criteria, or reductions in state funding to any of these same departments, whether it's behavioral health services, public health services, or in this particular case, state-funded Medi-Cal, that is on top of the risks that we face federally.
And if I can just add, from a timing perspective, we'll learn about the governor's reaction to these shortfalls in the May revise in mid-May.
Yes, that's right. So I know in the past we talked about potential or hope that perhaps the state might make up some of the difference of the cuts from the federal government, but are we now looking at the opposite, the going negative at the state level too? And if so, how does this, because I know we've been working to get more folks enrolled, and that's been part of the new revenue generation, but if there's, nothing, the state's doesn't have the funding, then are we going to hold the line now, or how are we going to move forward with this?
Yeah, well, until the state makes a change, it's obviously far more beneficial for people to be enrolled because they get access to coverage and care they otherwise wouldn't have access to in the same way, especially preventative care. And, you know, one of the things that I think is challenging in terms of the conversation around state-funded Medi-Cal is, you know, what does it mean when we say all of a sudden there's a lot more enrollment than projection? What it means is that there were so many thousands of more individuals who didn't have access to health insurance. Sure. Now they have access. What does it mean when we say there's utilization? It means that there's people who didn't have access to preventative care who are now coming in for care. Is it surprising that, you know, somebody who, for example, you know, hasn't seen a doctor in many, many, many years, except for maybe an emergency department visit, has a number of untreated or undertreated health issues that now they're getting treated, therefore resulting in higher utilization? No, that's not only not surprising, that's precisely why you want these folks with coverage, because then what you're trying to do is change the long-term trajectory of how you're spending your health dollars and shifting it to that preventative care. And so I think one of the messages that we really need to help educate the legislature and the governor's office around as they consider this is they're not really in a position yet, given how new this most recent expansion is of the program, to know how much of this is a long-term cost and how much of this is representative of a significant amount of deferred care, and the savings associated with having people on actual health insurance and able to access preventative care don't get realized immediately, they get realized over time. And so the irony here is, with conversation about scaling that back or cutting it, is, you know, the state may, from both a obviously healthcare perspective, be doing the wrong thing, but from a fiscal perspective, maybe doing something very short-sighted, because you actually need to have a few years of program to then see what that impact and effect really looks like. So, you know, that's all going to be part of the conversation. We're obviously going to be engaging heavily on the issue. It's really part and parcel of, you know, the values of this organization in terms of actually trying to make sure people have access to robust preventative care and not just showing up in you know, the emergency room. And the state, I think, would be well served to see this through for a while before reaching premature conclusions about what's actually long-term sustainable and affordable with the program, instead of jumping to a conclusion based on an initial spike in utilization that maybe they should have planned better for, but that's not surprising if you think about it.
If I could just add that in addition to what Mr. Williams just identified as maybe a short-term spike there, the state's already acknowledged that other aspects of this deficiency are likely one-time. For instance, there's something called redetermination, where people had eligibility during COVID for Medi-Cal that continued on and on and on. Okay. And then in the last year, they were forced to requalify for Medi-Cal, and there was a fear that there would be this massive drop-off, and some of the state's budget assumptions were based upon fewer people surviving redetermination, but in fact, in large part because of the county of Santa Clara and other counties that aggressively worked to keep people on the rolls, the drop-off was less than they anticipated, more people on Medi-Cal, and again, a spike in costs. So again, the deficiency will be addressed by the state. There's no question about that. Okay. And I don't think the state's in a mode yet to anticipate that this is a long-term structural issue yet. There's more debate to be had.
Okay, thank you. Yeah, there's so many competing interests, and you know, the hallways are just full of people with, you know, asks left and right, and so yeah, it just I guess reinforces the importance of us to be diligent, and I appreciate your work, Mr. Margolin, and our IGR staff, but the importance of advocacy and really trying to illustrate to the legislators what this means in terms of our folks. So
yeah, and I would just add, Supervisor, I think you're spot on. There's so many competing interests, you know, in the face of what's coming from the federal level to the state, there's no question that our legislature and governor are going to be put in a very challenging position, just as we are, right, at the local level, but we'll be in a very challenging position. I think you're absolutely spot on, of having to make very, very difficult and not pretty choices. And so it's important that we're part of those conversations to help also keep the perspective focused on the long run and what important infrastructure needs to be maintained to serve folks, and and the fact that counties in particular, with the kind of funding streams we're talking about for our organization, are ones that are really directly related and fundamentally and inextricably are linked to people's lives, right? Their literal health and well-being, and in ways that other programs, while very important and we would not denigrate them, don't have those same stakes.
Thank you. Thank you, Chair.
Thank you. I'm pausing because of the amount of things that's really changing here that is really disconcerting. There's something minor I just want to bring up first. Let me deal with that first, Paul. This report will be coming back to us, and as far as the title is concerned, I would just ask to add the word counties before the word counties efforts to clarify that this is really something of what we're going to do to address these different impacts. And given that's what we're doing, maybe for future, it might be better for Mr. Margolin to go first, talk about what the impact, what's going on, and then how we are going to deal with it afterwards. So it might make sense for him to bring us the bad news, and then what are we going to do to fight these bad news, let's say. Would that work, Paul? Yeah.
Yes, Supervisor.
Yeah, sure. That's fairly minor. And then the thing is, we will need to work with not just ourselves, but partner with other agencies and whatnot to work together to protect the health and well-being of our county as a whole. So I would like to ask to also include the CHP, the Community Health Partnership members, to help provide some of these information to work together regarding how to fight the potential cuts to Medicare, Medicaid. Because being a respected community partner, I think they certainly would help provide some good ideas for us as well. That makes sense?
Supervisor, we can include who we are working with in the community around these various issues, and I would just simply also share with the chair and Supervisor Abakoga that James Williams and I did have the opportunity to meet with Community Health Partnership around this very issue.
Good. One thing I have said this before, and James have heard me said, is the impact of these cuts to Medicaid. We keep saying potential cuts to Medicaid, but I think it's obvious the issue is not what if, it's a matter of how much, right? Different numbers we've heard, 880 is what's on that bill. When I was in DC a few weeks ago, they said, "Oh no, that's not the ceiling. That's just the ground, the basement." We expect this to potentially go up to even $2 trillion in order for that to match the tax cuts, which is another couple of trillion more than that. So the problem with these big numbers, when you tell the general public, "Oh, it's $880 billion or $880 million," you and I understand that's 1,000 times of a difference. But to a lot of people in public, those numbers are just so big that is frankly incomprehensible. And so keep talking about numbers is important for us, but in terms of getting the word out to people, of able to explain what's going on, I think the only thing that would work are heartfelt stories of our community of how it would impact us. In other words, what type of pain people would be feeling if they are getting IHSS, like there is one example I used during the state of county, right? Half of the funding is going to be from the federal sources, so potentially you could, half your pay could be gone. I mean, that's using one example, but really make it much more digestible, much more heartfelt, and in this case, maybe videos, right? I really think it's really needed because of our unique position of having 4, right, hospitals starting April 1st that we'll have. I think we are in a very special position that we could tell these stories. Why I'm saying that is because when I was at the NACO conference 2 weeks ago, I was sitting next to some of the commissioners. They come commissioners or supervisors from other counties. And after so many times the NACO conference has provided us details and numbers and statistics and graphs of what these impact of Medicaid, how negative that will hurt so many counties. Every county, and we know about red county, blue county, it doesn't matter. Every county will be hurt. Our residents will be hurt. And the comment I got back is like, you know what, it won't hurt us very much because our county don't own the hospital or that, and it's owned by the universities. Oh, by the way, yeah, we rejected the Biden, Medicaid funding earlier, so we didn't get that anyway, so it won't going to affect us much. Folks who are supposed to know are so wrong on the facts, and it's sad because people are not getting it. And right now, basically, there are different bubbles of information, but math is math and numbers are numbers. In this case, cutting Medicaid is going to hurt every single county's hospital system. Is not a red or blue point. It's just a fact. So I really think it's so important that we engage in more of this content generation, shall we say, to tell that story. Because until that story is being told, people really get it. Oh my goodness, really? Is that what's being proposed? That doesn't make sense. I think we need to reach that in order for this train wreck to hopefully slow down. Does that make sense, Paul?
It does. I think we have to take it down to the personal level. At the press conference yesterday, we had the father and family there, and I think obviously everything that was said was powerful, but I think the most connection that occurred was during that period of time when the father was up there speaking about the impact to him and his family and to others like him. So.
In language in some ways, right? Because it's not just English. With our diverse population we have here, people understand different languages.
That's correct.
Because I could tell you right now, listening to some of the other languages broadcast, a lot of people are still believing that, oh, all this is great. We are cutting fat from the government and inefficiency and cutting corruption. So all this is good. And that's the mantra that you keep hearing from the side trying to advocate for these cuts, as if there's very little or no impact to them. But who is them? It's all of us is the problem. So I think it's so important that we are able to do that. So I just want to throw that out and ask our administration to work harder to gather these stories and make some content production to tell these stories. And with that, may I take a motion from my vice chair?
I will make a motion to receive the report.
Okay, and I will second that. And along what I just said, I'd like to request our Santa Clara Valley Health Hospital work with our OCPA on some type of educational effort to gather personal stories about the importance of medical services and sharing these stories for our county social media and other information with the public. All right, I've got a motion and I'm seconded. And
Vice Chairperson Abe-Koga?
So the motion includes your...
Yes,
Okay,
absolutely,
great.
yes.
Thank you. Aye.
And Chairperson Lee?
I as well.
Thank you.
Okay, I do have a few questions later. Maybe Bert, we could connect regarding Prop 35 and some of the other issues, but let's hold off on this one issue right now because I think it's so important that we clearly state what is really needed for our county to come up with. All right?
Okay.
Thank you.
Thank you.
All right, moving to item number 8 is receiving quarterly report from the EMS agency regarding the EMS system operations activities. And here to present, I believe, is our Director of EMS, Nick Lay. Good afternoon.
Chair Lee, Supervisor Abe-Koga, good afternoon.
Good afternoon.
Before you have our quarterly report for quarter 1, 2025. Happy to answer any questions that you have any.
Great, thank you. Anybody in public would like to speak on this?
I do have one request in chambers.
Okay, 2 minutes.
Okay, we'll close the queue for requests. Our speaker in chambers is Robert Sapien Jr. You'll have 2 minutes. Please go ahead.
Thank you very
Good
much.
afternoon, Chief.
Good afternoon. Very glad to be here today. I'm reminded of the importance and the weight of the issues that you all work on. Thank you very much for your work here. I did get a chance to review the quarterly report. It so happens that it aligns with the annual report that I will be providing to the City of San Jose's Public Safety, Finance, and Strategic Support Committee tomorrow. The reason I'm standing before you today is I think there's a need to harmonize a little bit, because I think the conversation that I'm going to be having with my council is going to be very different than the information that's in the report. Specifically, I will be needing to, I'm guessing, answer to the 1,477 transports or instances where the San Jose Fire Department was required to transport patients to hospitals because ambulances were otherwise unavailable. And I will also, I suspect, be responding to questions about the 1,113 times firefighter paramedics had to be pulled from their fire trucks and fire engines to ride in on ambulances that were basic life support status rather than the originally required advanced life support status. So in order to maintain advanced life support care for patients, our firefighters are jumping into ambulances and responding to the hospital. I think certainly none of that is a signal that we would not do what is right for the community ever. Of course, if we are needed, we're going to do whatever it takes to make sure that our residents get the services that they need. But I did feel that the report was lacking in a little bit of that depth and understanding that our agency is very strained right now. Those extra duties that are otherwise not supposed to be the responsibility of the San Jose Fire Department are straining our ability to respond effectively to all emergencies. So thank you very much for your time.
Thank you. Let's see, we'll close the queue. No more public comments. Yes, go ahead, Vice Chair.
Thank you, Chair, and thank you for the report. I know that I think my predecessor had asked for quarterly reports, so I appreciate seeing this. My focus on with this is the upcoming end of our current transport contract. I believe it comes at the end of December 31st, 2025, with 3 one-year extensions. I read that there's a plan to have an assessment conducted before the RFP process. My concern is, and frankly, I've watched this for 17 years now since as a former council member, when I first got onto the council there, and anticipating an RFP process, but the current contract is in its 9th amendment, so it's been continued 9 times. And I have heard, and I've seen it, frankly, from my own community, my own city, but there's a lot of concern with the current system and the lack of staffing, the long response times, wait times. And I appreciate that the assessment is meant to look at all that. But my real concern is that we do actually do an RFP this time around. And I'm concerned about the timeline, the year of assessment we're looking at. I know RFPs takes at least 6 to 9 months to put together. Then you have to go out to bid, and then there's going to be transition time if that someone else is chosen. So I guess I would like assurance that we're going to make the timeline, but also I'm aware that there have been other assessments conducted in the past, and so my first question would be, can we just utilize some of those to cut down on the time that this is going to take?
Let me answer those questions, Supervisor. So first, on the RFP process, we actually did go out and do an RFP, I want to say 2016, 2017 timeframe. So there's been an RFP since the 2011 contract. It was a failed RFP process. And the reason I just want to mention that is because one of the reasons we want to do a comprehensive system assessment and not rely on some of the work that's happened in the past is because the current foundation of the current contract and system is based on an outdated model that is exclusively an ALS model. And so we could put an RFP out on the street very quickly that's basically a repackaging of that prior RFP. I don't think it'll result in addressing the concerns that stakeholders have raised or the concerns that the EMS agency has or the rest of the county organization has. I think it'll likely result in just a renewal of the same structure of contract, potentially with a different provider, possibly, but not fundamentally a different structure of a contract. And that's one of the reasons why when I stepped in the county executive role, actually asked for a different assessment to be done altogether. So, I think we have an obligation to actually do a review of what type of structure we want to go back an RFP for. Make sure that it's one that has the right kinds of models that are relevant to the changes that have happened since 2011, so that we actually can then get back something that can address some of the structural issues that we've been facing with our current system. The timeline for doing that has slipped. That
Yes, that's my concern.
and it's a legitimate concern. I think it's a reflection of the reality that we have limited bandwidth, and so this is an item that that people get pulled away from to deal with other things. So I'll give you the most recent example. EMS agency was told it needed to be in a position to certify restoration of trauma status at Regional Medical Center by April 1, and clear direction was given that that had to be prioritized ahead of all other projects in the last several months. So that's one by way of one example of the kinds of things that come up for a department that's otherwise a very, very, very small department. But I think there is a need to actually have that assessment done to then go out with something that makes sense.
So I appreciate that, and I again, my concern is the timeline, and I know everyone is stretched thin, but just as we were talking about Medi-Cal and healthcare and people's lives, this is about people's lives too. So I think I put this as one of the top priorities, and so that's really my interest and concern, and that we get this done this time around. I will say that the challenge, and again, I've studied this quite a bit for myself, because I saw the challenges and frankly some of the problems that were being encountered. But I appreciate Chief Sapien being here, but there's a real responsibility put on the cities or the municipalities and the county too, the county fire department, and a lot of unrealized or unseen costs that frankly the public agencies I feel are subsidizing the current system, and that's my concern, and that's the concern that I've heard from many cities. San Jose, I know, has been looking at this. Sunnyvale has just commissioned a study on alternatives. And so what I want to ensure is that we do, and I appreciate that your comment, Mr. Williams, about how the nature of the industry, the job has changed. So I appreciate us looking at that. But I really think we need to, I just want to make sure that we are inclusive and comprehensive, and we recognize what each entity, agency is contributing. When I look at, the RFPs, there's I think some costs that are not actually, included in and the bids, because there is this, frankly, subsidies that are being provided by the cities. And so, for me, that's what I'm looking for, is something that's not going to put, frankly, anybody out financially, and that provides the best service, increased response times. As Chief Safia mentioned, the costs of having paramedics on the ambulances and putting the rigs out. I want to make sure that all of that is being covered in this assessment, so when we get down to the RFPP, we really have apples to apples comparisons, and are able to make the decision on what the best service delivery model is. And frankly, I think, I've looked at this enough that I don't know that one entity or the other can do it. I think it's going to be a more collaboration and I think perhaps a partnership model. But I just want to make sure that we look at that all completely, recognize, all the financial pieces to this, and then make sure that we get this done in time. So I'm not sure, I guess we'll have these quarterly reports, and perhaps that's the way to monitor this, but I just want to ensure that we get to the finish line. Thank you.
We're definitely all very committed in getting to the finish line, making sure that we address some of these very long-standing challenges, and exacerbated by the fact that the private sector ambulance providers have shifted so significantly too. I wasn't involved in anything related to the ambulance system, but I was here at the county when we contracted with Rural Metro, and it was a shift in providers from AMR. Now, of course, a few days later, it felt like, but a few years later, AMR then buys out Rural Metro, and we're back with AMR as the provider after having gone through the RFP process to shift providers. And after getting, in that base 2011 contract, extraordinarily good contract terms, but terms that have been very challenging to effectuate and put into practice. And so there's some lessons learned from that, and then of course AMR ends up now today actually owned by a private equity firm, and we know the story around all of that just more generally. So this is a continuously evolving landscape, and what is clear is that we need to have on a go-forward basis a different structure for the system that actually works for everybody.
Okay, thank you. I do have a couple of questions. One, when I was looking at the report on page 4, on the first responder code 3 performance, looks like where I live, Sunnyvale, has one of the worst numbers here, not meeting the standard. So I'm not sure if you have the information now, or you could give us an off-agenda report regarding some of these compliance issues for the first responder response in Sunnyvale.
Yes, Chair Lee, we'd be happy to give you an off-agenda report.
Okay, good. On the ambulance offload time exceeding 30 minutes, as shown in Figure 6, are there any changes to protocols to able to support these delays moving forward? And also, in the expectation after April 1st, we will have level 2 trauma back at Regional Medical Center. Would that be able to give more opportunities for RMC to take some of those, so that will lessen the wait time?
Yeah, it's a fairly complex components that make up what the ambulance patient offload delays look like. So certainly bringing the regional facility back under the county flag and re-upping level 2 will add some relief. But additionally, working with our Valley Health partners to really find opportunities to both redirect patients to appropriate facilities, change maybe some practices between our two organizations to really enhance that partnership to reduce those times. We are working quite diligently to make policy changes as well as some destination changes to support patient load balancing.
Good. On the need for EMS new personnel from our county, within that professional standards section, it shows that efforts are ongoing to support credentialing and education, support more new professionals starting work there. How is that program going on, and are we really closing that gap?
Certainly, Supervisor Lee, there still is a gap, as we would expect. It does take time. AMR has just launched a brand new paramedic program within the county that we just authorized. So we do expect those yields probably about 9 to 10 months from now, at the soonest, if not a couple months after that. Additionally, as we work to fix ambulance patient offload delays across the county, that should reduce some of the burden and help close that gap.
Okay. We talk about ALS, we talk about BLS, right? So, and we have this nurse navigation program designed to divert calls away from ALS and BLS ambulance responses. So, do you have any idea how this program is doing?
Supervisor Lee, it is a slow beginning. We did limit our geographical footprint as well as the agencies involved, so the call volume is a lower call volume. We are excited to report that here in the next several weeks, we will be launching what's called the field referral component of that, which allows field providers to more proactively find patients that may meet this criteria to really reduce the burden of patients. So hopefully here in the next several weeks, or our next report, we'll be able to provide updated numbers that show progress in that program.
Good, thank you so much. And that's all the questions I have. And Supervisor Abacoa, would you have a motion to receive the report?
Yes, thank you, Chair. So I will make a motion to receive the report, and then I would like to include some items in the assessment that will be conducted. And so I'd like to ensure that the assessment includes costs associated with dispatch, local contributions, including staff ride-along and EMS vehicles, rig out-of-service times and costs, dispatch costs not covered by the EMS provider, local jurisdictions' equipment costs to operate as excess capacity not covered by the provider. So this will hopefully ensure that we see the true total costs, including the agency's contributions. And I just want to confirm, so timeline-wise, if this is to start May and June of 2025, we're looking at a year, so we come up on 2026, and then the RFP would take 9 months, perhaps. So we come into March, let's say March of 2027 to put and then how long is it usually? 60 days, a month, 60 days for the RFP to be out?
Supervisor Abacoga, it typically takes about 12 months is what you would allow for a ramp-up period if it is a different provider. If it is the same provider, that obviously it could be shortened.
So we have three one-year extensions, so that will take us to the end of 28?
Correct.
So if everything works on time, we'll look at spring, summer of 2028 to award the contract. And
in an absolute ideal scenario, that would be what we'd hope for, pending any other challenges that may be presented.
Okay. So, so I know we'll get quarterly reports, and I would just ask that if anything starts to go awry on this, that we're notified and we can talk about alternatives.
Okay.
Thank you.
All right, I'll go and second that. No further comments. Let's take a vote.
Vice Chairperson Abacoga.
Aye.
Chairperson Lee.
Aye as well.
Thank you.
Thank you. Moving to item number 9, regarding emerging issues impacting our county. First, Jess, do we have any public want to speak on this item?
No request to speak at this time.
All right, close the queue on that. So, all right, I'll go ahead and defer it back to you, Paul.
Thank you, Chair Lee. I just have one item, which is really to express my gratitude and that of the entire healthcare system to Dr. Cody. This will be the last time I actually sit next to you. Is that correct? Huh?
On the dais.
On the dais. On the dais. On the
this
dais.
dais.
But it's just been a phenomenal time in working with you as a professional and as a colleague, and you will be missed.
Thank you. Dr. Cody, you want to say anything?
I don't have any particular updates other than that I wanted to express my gratitude as the last time that I sit here in Health and Hospital Committee meeting. to thank the leadership of the Health and Hospital Committee. I love this particular Health and Hospital Committee. You are so gracious and gentle, and it's lovely. Also, as always, want to thank the county executive and my colleagues here. And I also want to thank the clerk of the board. You are so lovely, the way you guide us through the meetings. And I would be remiss if I didn't thank the sheriff in the back of the room for keeping us feeling safe and secure. I have a particular warm place in my heart for the sheriff from the pandemic. I think that I'm leaving our department in really excellent shape. A former supervisor advised me long ago that if you always hire people that are smarter than you are and advise them to do the same, good things will follow. And that's certainly been my experience in the public health department. So I have enormous trust, respect, and faith in the leaders in the department. And I think that we have bumpy times ahead, but we'll be in good shape. So thank you.
Thank you, Dr. Cody. I do want to share another word on this as well. Is that really want to thank you for the 26 years of service and your partnership for the past 4 years when I've been on this board. Many understands that you really, in so many ways, being the public face during COVID for this county, making this really one of the hardest job because talking about not allowing large gatherings, issuing the first shelter-in-place order in our country, and getting our residents tested, vaccinated, and making these very really life and death decisions, right, to help steer our county into the better health and protecting so many of us here is nothing less than remarkable. And prior to pandemic, most people don't really know what the public health officer does in the county. Mm-hmm. But until that moment came, and you certainly have stepped up and filled the role, your exceptional leadership, this is something that you have done not so much because of power of a position, but you have done all this with grace and humility in the face of many adversity and uproar from the community members that unfortunately has been misinformed, misguided from different information bubbles. Your development, your leadership led to the development of the science branch, supporting data-driven decisions, improving our public health, and prepare us to respond to our next pandemic, whenever that may be. So I'm just want to say I'm so grateful for leadership and partnership and to bring us to a better place. Now, after saying all these good things, now I have questions for you before you leave. H5N1, not letting you go so easy. We've been reading a lot about the various cattle infected with it and birds that have been, and chickens, and of course that's also part of the reason why our egg prices is very, very high. Can you share with us what you have learned most recently and what do you think, where this is going?
Well, as I said before, we're not, we don't have a big dairy industry in the county. We just have our one dairy with 4 cows. I think that H1N1, like really any other emerging infection, what's really important are the monitoring systems. And in order to monitor it well, you have to test and you have to stay ahead of the curve. We don't have a lot of leverage here in Santa Clara County. We've, done what we can, which has included testing raw milk. And I think that, certainly it worries me, the changes and we depend on the federal government and federal departments to be testing in other states and our own State Department of Agriculture to be up on testing here. I guess some good news would be that we got through a very difficult influenza season with more flu A than we've seen in a very long time. And so far, we've not documented any reassortment events with the seasonal influenza virus and the emerging H5N1 virus, so that's good. I think that in our county, we have the systems in place to see something early if it comes, but that doesn't help us so much with what's happening elsewhere. So I guess I would say for the moment, no big warning signs, but it could happen at any moment.
Right. And then you mentioned the flu virus too, and I've mentioned this on Friday when we're doing the state of county. One concern I mentioned is the fact that the annual meeting of the, I guess, virologists who study the virus, try to predict what they are to come up with the vaccine for next flu season, those guys apparently was not meeting anymore. How is that going to affect us? Are they still? Is there some ways that work is being done, or is just not going to happen?
So I'm not sure. I also heard that meeting was canceled. Generally, there's other bodies that get together at the, for example, at the related to the WHO, to advise on how the next flu vaccine should look and what it should cover, usually based on what's circulating in the southern hemisphere. So I imagine that would be the go-to information for vaccine manufacturers.
For sure. Go ahead.
Thank you. Well, I'll just start by also offering my deepest thanks to you, Dr. Cody. I know we haven't had an opportunity to work here for very long, but I very much appreciate your leadership as in the 2020 era, and just from that sheltering. I still remember the sheltering in place day, and then those weekly meetings that we had where we all got together and really. I know, I imagine the weight of responsibility that you must have felt, because we were all just looking to you for your guidance and leadership. But I just really appreciate how you steered us so well for our county to have led the way in many ways through that hopefully once in a lifetime experience. So I just want to thank you for your incredible leadership and care throughout your 26 years, but especially during that time. But I do actually have just one more question regarding measles. So I've been reading about little outbreaks here and there, I guess mostly in the southern part of the country, but do we have concern in terms of any geographic or demographic areas in Santa Clara County?
Yes and no. In general, we're a fairly highly vaccinated county. We depend on data from schools, so we can look at vaccination rates by schools, and that's publicly available. In general, our schools are at 95% or greater vaccination for the measles, mumps, and rubella, which is terrific, but not every school. So we do have some worrisome pockets where if measles was introduced, there would be potential for spread. The other area of concern is international travel. There's lots of areas in the world right now with a lot of measles activity. I believe that all 5 cases of measles reported in California this calendar year are all associated with travel to Vietnam. So they're having a large ongoing outbreak in Vietnam, but that's not the only area of the world. So residents of our county who are not yet vaccinated because they're too young, or who aren't protected because they're not vaccinated or for another reason, would certainly be at risk if they were traveling to a place with a current measles outbreak.
Are there groups that should be checking their vaccination status, or do we get boosters?
There's no real recommendations for, there's certainly cases where someone might want to check their immunity, but there's no recommendation or need for people in general to go to their doctor and say, hey, I'd like to take my measles immunity. So there's certain cases, a healthcare worker in a situation where there might be more likely to be exposed, or if they don't have presumed immunity or something like that. But in general, no.
Great, thank you. The other question was regarding all the federal funding potential cuts and freezes. One of the programs that might be in jeopardy is the Public Service Loan Forgiveness Program, and was thinking how this relates to our shortage of physicians and potentially worsening the shortage. But do you have some suggestions or thoughts on what kind of steps that we could be taking to improve.
Gonna look to my colleague Paul
Okay.
Lorenz.
Thank you, Supervisor, for that question. So we do have physicians within our workforce that are employed that do have access to loan forgiveness programs and are currently enrolled. It's not a large portion of our physician workforce. In general, if any impact came about as a result of any federal changes, given what we know is the uncertainty coming out of Washington, I do not anticipate that it will affect our ability to recruit and retain physicians. I think what's really going to be telling is, what impact on the types of healthcare services that are going to be available to the community and our ability to deliver on that in general. But I do believe we have the ability to attract and retain quality, mission-driven physicians for our community.
Great. Thank you. And thank you again, Dr. Cody. Thank you, Chair.
Thank you.
Yeah, thank you so much, Dr. Cody. And just follow up on that issue, I didn't realize that the Vietnamese community tends to be one where, due to travel, just want to know, is it something that we've done, or would it be wise to do some PSA in language to some of our minority communities about measles now that we know it's rearing its ugly head?
Yeah, I think we've just seen actually some pretty good materials come out from the state health department in multiple languages that we may want to use. So again, the concern is travel, returning travelers. And just for the record, anyone traveling with the baby, usually children have their first shot between 12 and 15 months. And then the second shot around kindergarten time, between age 4 and 6. But if a family needs to travel and has a young infant, infants can get their first shot as young as 6 months.
Okay, great. Yeah, so I hope if we could get those messages out to our community, that would be
Yes.
very, very helpful.
Yes. Thank you.
Yeah, thank you. All right, thanks. Hi, Sherry. Oh, Dr.
Hi.
Terrell, sorry.
Good afternoon,
Good
Chair
afternoon.
Lee and Supervisor Ave Koga, Sherry Terrell with the Behavioral Health Services Department. You have our written report. The only addition is around the claiming. And so we had shared a couple of meetings ago that the state had allowed counties to come back and resubmit denied claims during the period in which CalAIM payment reform was being implemented. And so we reopened the opportunity for our contract providers to file those claims. And as of March 11th, 7 agencies have submitted claims. We did meet with our providers the other week, just reporting that back, and many other agencies will be working on resubmitting those claims. We do have open windows to submit those claims through April 15th. And so we anticipate many of our agencies will continue to work on resubmitting those denied claims. That concludes my report, but I also did want to extend my appreciation to Dr. Cody on your retirement. Just wanted to thank you so much for your leadership and guidance, not only to our entire county, but just the care and consideration that you've shown to me personally in my role. I've really appreciated that, and just know that we will continue to partner with Public Health and Dr. Rudman and others, and look forward to that continued partnership. But I just wanted to wish you well. Thank you for all that you've done for us.
Yes, go ahead.
Thank you, Chair Lee and Supervisor Abikoga. You have our report. I'm happy to answer any questions.
No, I don't have any questions. Do you, Vice Chair? Okay, no.
And I'd just like to add my sentiments, how much I'm going to miss working with you, Dr. Cody, and what an honor it's been to serve with you. Be greatly missed.
All right. If no further comments, I'm ready to receive the reports. Have a motion for receiving all these reports, Vice Chair?
I'll make a motion to receive the reports.
All right, on item number 9, and I'll second that. No further comments. Let's take a vote.
Vice Chairperson Abikoga?
Aye.
Chairperson Lee?
Aye as well.
Thank you.
Okay, and right now, let's see, I think we are now adjourning for the meeting. I believe the date for the next meeting might be changed. There was some initial date of mid-April, but I'm actually moved to, I believe, April 30th, I believe. But you know what, let's double check on this one, Vice Chair. We can confirm.
From the clerk,
Yes.
I'll be processing a cancellation reschedule notice for April 30th at 9
April 30th,
a.m.
yeah. Thank you so much, yes, yeah. April 30th at 9 a.m. is the current proposed time for this next meeting. Thank you
Thank
very
you.
much. Thank you.